This conference will now be recorded.
Hi, everyone, and welcome to the AnCan High Risk Recurrent and Advanced Prostate Cancer video chat from Monday, March 18, 2024. I'm Len Sierra, and I'll be moderating today with a little help from my moderator friends and from everyone else here. Thank you for attending. We want to start off thanking and acknowledging our sponsors, and they are Bayer, Janssen, which I guess is now going as J&J, Myriad Genetics, Novartis, Telix, and Blue Earth Diagnostics. And I believe that's the correct up-to-date list. So I don't believe we had anyone new, did we? Oh, Richard Fisk.
Yes,
You
I
can
was
hear us.
finally
You're
able to get
Yes,
new.
the system working.
yes,
Terrific.
Mr. Fisk is back with us with his system working, Len.
And
Yes,
you're
I had.
new, aren't you?
Yes, sir.
All right. So you know how this works, Richard?
No, I don't. Well,
Okay, well,
Jim has given me a little bit of a heads up.
all right. I'll just go through a series of questions and just answer the questions as they come up. We'll try and keep you in a chronological order so we don't get confused
Okay,
in, in your treatment cycle. So, how old are you, Richard?
I'm 76.
And when were you diagnosed?
Early 22. Well, actually, I had the biopsy was MRI in August of 22. That was very suspicious based on an earlier high PSA, and a definitive biopsy on 30 September of 22.
And what did that show? What was your Gleason score?
4 plus 5
Okay,
equals 9.
okay. And so you said they did an MRI and any other scans?
Uh, yes, was PSMA was also done,
Oh, good. Glad to
and
see they're doing Glad to see they're doing PSMA scans on newly diagnosed folks with Gleason 9. And what did that show, Richard?
it showed nothing except for um, the end of one floating rib, which was uh, diagnosed as an artifact, an anomaly, because that is so rarely active.
Okay. What was your PSA at that time?
I don't recall what my PSA was at that time. It was elevated from what I had previously shown. I had been insisting on PSAs annually, despite the recommendations, and that was very helpful.
So, what was your PSA as you last remembered it?
Uh, I w-
Just a
for
ballpark, like 5 to 10, 10 to 20, 20 to 30.
5 to 10. It was
Okay,
not it was not that high, but it was the trend that was disturbing.
right. So that was September 2022. And then
That
what
was
treatment,
that
right?
was the biopsy.
Yeah. And what treatment have you had since?
I began hormone therapy in on October 27th with Lupron and Zytiga,
Okay.
and which actually uh, shrank the cancer. In August, the tumor size was 9 by 11 by 12, and by January it was 5 by 9 by 11
Wait a minute.
You're talking about centimeters,
millimeters.
millimeters. So that's pretty small.
Yeah, the um, I had external beam radiation followed by uh, high dose brachytherapy,
Okay.
and
Good.
that was in January, February, and March of 23.
And I forgot to ask you, Richard, where do you live?
Alexandria, Virginia.
Okay. Another one. That's a very popular area for our group. And let's see. So what treatment have you had, if any, since your radiation in spring of or early 2023?
I I have only had the hormone therapy, the
You're still
Zytiga and Lupron.
so you're still on that now?
Yes, the original course was going to be 24 months, but based on some recent studies, and just a couple of days ago with my hematology oncologist, he's looking at reducing it to 20 months.
Okay, I guess you're undetectable.
Yes, both testosterone and PSA are undetectable, and have been
And
since I started.
oh, since you first started or soon after you started hormone therapy?
Soon after I started, the PSA went to zero and stayed there.
Terrific. Which institution are you being treated at, and who's your medical oncologist?
Fort Belvoir, Virginia, and the um, onco- radiation oncologist is Dr. Carlin, and the hematology oncologist is Dr. Verma.
Okay. And do you know if the Dr. Burma is a GU medical oncologist, specializes in prostate cancer and GU cancers?
I I believe he's more of a generalist, and the
Generalist?
name is Verma, Victor, ERMA.
Oh, okay. All righty. Anybody, Rick, or anybody know who that is?
I think this is the. Are you being treated at the VA, Richard?
No, this is at the Fort Belvoir Community Hospital. It's a military hospital.
Okay, so it is a military hospital, but it's not the VA,
No,
correct?
correct.
No.
Right. So then I'm sure he's not, because the military hospitals don't have any specialized GU medical oncologists.
Uh,
Affirmative
yeah.
at that, Rick. Affirmative.
All right. Thanks, Jim. Um, what about genetic testing, Richard? Have you had any germline testing or somatic testing?
I have just had the swab taken last week. Because I'm looking downstream and I want to determine what my genetic endowment was. So that is in process.
Okay, so no, they didn't do any genetic analysis of your tumor tissue when they did the biopsy.
No.
Okay, let's see.
So just to clarify one thing, you said your PSMA test didn't show anything. Is that correct?
Yes,
Except the floating lesion on the end of the rib.
correct.
So where is this lesion that you say shrunk, and
Oh,
how was that found?
that was the prostate tumor itself within the prostate.
Ah, okay. So that,
I'm
that
sorry I
that's
wasn't
that's the
clear.
tumor within the prostate.
Yes,
Got it.
the tumor was fully contained within the prostate, but it was projecting onto the rectum, and so I had a flex sig with an ultrasound uh, as I was getting into the radiation process to
Mhm.
see whether the rectum had been compromised, and it had not.
Okay, great. Okay.
Well, you're a fortunate guy. There aren't many Gleason 9s that are wholly contained and whose subsequent treatment kept it at undetectable so far, at least. You're doing well. Richard, do you have any questions for the group here?
Yes, I do. What I'm recently I have started having rectal bleeding, and I had a colonoscopy a week ago, and uh, the diagnosis was proctitis, and there was a spot in the colon that was compromised and bleeding, and the decision was made not to use a laser to try and cauterize it because of the danger of perforating the colon.
Yeah.
So I'm dealing with that. The other questions I have to do with recurrence and dormancy. Uh, what keeps, how do I know if I have dormant cancer cells, which is kind of an oxymoron since their uh, dormancy is non-responsive. What lifestyle, diet, whatever uh, activities or changes will keep them dormant? What would activate them? And uh, how do I identify if any exist? What I'm looking for is how to preclude recurrence, since I appear to be fairly lucky so far in getting diagnosed and getting treated with what appears to be state of the art or near state of the art treatment. I wanted to have a prostatectomy, but that was not recommended. And I went up to Johns Hopkins, got a second opinion, not recommended. Talked to my brother on the West Coast, a radiologist, who talked to the University of San Francisco folks, not recommended. So that's why I went with radiation.
And we would probably agree, not that we are medical, we can give medical advice, but we would suggest that any man over 70 who wants a radical prostatectomy should seriously dig into that with his medical team. So the the treatment that you had, which is EBRT plus high dose brachy plus 18 to 36 months of hormone therapy, including abiraterone, has been shown to be the best. So you're getting the right treatment.
I've done a lot of poking around with studies and NIH reports and things like that. And as best as I can determine, I concur with that. I think I'm getting the best that's available for my situation.
So, Richard, one of our guys would like to know, did you have the spacer hydrogel inserted between your prostate and rectum before they radiated?
I
Did they
asked,
talk to you about?
I
Go
asked
ahead.
about that, um, discussed it with my brother, who didn't think it was appropriate, but also with the radiation oncologist, who did not think it was appropriate. So that I
Okay.
didn't. That's why I did not have that. I
Yeah.
knew about it, but did not use that.
So when you said there was a lesion or something that was your rectum was compromised, what
Yeah,
was that?
there was a spot on the rectum found by the colonoscopy that, and I've got a picture of it. It's a red spot that had a blood clot on it that was knocked off, and that's where I'm getting my periodic bleeding.
Presumably, this is John. Presumably, did they assume that it was radiation that caused that?
Correct.
Yeah.
And there has been no evidence of colon cancer. I've had some polyps removed, but nothing but radiation is that's the virtually certain that's responsible.
Did they recommend any therapy for the bleeding since you said they couldn't cauterize?
Increased fiber consumption, and that's
Yeah.
all I've got.
Okay.
If there is something more, I would be interested to hear it.
There are a few other options. Not sure how effective they are. I think the argon plasma therapy, which is the cauterization, is probably the most effective. But there's sometimes uh, steroids inserted rectally are helpful,
Hmm.
or sucralfate, I believe. Um, Anybody else know of any other potential treatments for proctitis? Maybe I would get a second opinion on that from somebody.
I will do that. It was an experienced GI doc who did the colonoscopy and knew what to expect, was prepared with the laser had he thought it necessary and appropriate, and made the decision that he would not treat it.
Hmm. So other
It's
than the
interesting.
bleeding,
It's interesting you say that, Richard. The GI doc, did he know this was before you had the colonoscopy? Did you have the bleeding before the colonoscopy?
Yes, uh,
Yeah. So
and he
the re,
knew ahead of time that there was bleeding, and he
yeah,
was prepared
well,
with the laser.
yeah, the reason it's interesting and you call him an experienced GI doc is because um, my own radiation oncologist stopped me from having a colonoscopy for several years, literally, based on radiation proctitis. He said, look, go for a sigmoidoscopy, but the risk of creating a fistula with a colonoscopy is too high. And probably 3 or 4 years after my treatment, maybe even 5 years after my treatment, he said, okay, go ahead and get the sigmoidoscopy. And I think it was a good 7 years before he let me have a colonoscopy. So I wonder about a doc who's aware of this, who's going straight in with a colonoscopy. Just a heads up that if you
Mhm.
continue to have that bleeding and you want to get another colonoscopy, you might want to get a second opinion whether it should be a colonoscopy or a sigmoidoscopy, because if there's a stressed point there, the colonoscopy can cause a fistula, which is the last thing that you want, which is the same as a perforation.
Okay. The radiation oncologist who did the high dose brachytherapy had recommended waiting at least a year before doing uh, a flex sig, and um, uh, it has been exactly a year.
Yeah, but you didn't do a flex sig, you did a colonoscopy,
True.
right? And he
Yes.
probably would have been even more aggressive on telling you to hold off if he'd known you had some bleeding recently. So I'm just saying, look,
Hmm.
thank God nothing, you were good and everything was okay, but just be aware that if you do have bleeding as a result of radiation proctitis, which several of us on this call have had, be very wary about getting a colonoscopy. And, check with your radiation oncologist what they think. And maybe they'll recommend a flex sigmoidoscopy, as your radonc was talking about. But I just want to encourage people to check. Don't just dive into a colonoscopy if you've had any
Hmm.
sign of bleeding.
What given given that that's where I am, what are my alternatives now?
Well, I mean, first of all, you probably don't need a radiation. You don't need another colonoscopy for another year, right?
5 years.
5 years. So between now and 5 years, you'll see how you are. You may not have had bleeding in 4 years by that time. We got a bunch of questions, Len, so I'll let
Yeah,
you
I'm
handle them.
waiting to cut in there, Rick. All right, Jeff Wood, go ahead.
It's interesting. I just had a colonoscopy two weeks ago, and I warned them, that I probably had damage to that area from radiation, and they did have a little bit of a problem and told me they had to use a smaller implement, and that might be something too that they could do for you in the future as well.
Well, they did use a pediatric pediatric scope,
I
a
didn't say that
smaller
small.
scope. Yeah, they did use a small scope.
Yeah, good. I was
Very
surprised.
good.
I ended up with spasms, and I think it was probably related to them trying to use something too large.
Okay.
Jeff Markey, you have a question?
Well, not a question, but a comment. He'd asked something
Yeah, go
about
ahead.
you'd ask, one of the things you can do is stop eating red meat completely. A
Done.
vegetarian diet, people with a 9 have actually gone many, many years on a vegetarian diet. You can eat salmon and maybe, or not salmon, fish and maybe chicken, but stay off the red meat. This has been discussed many times in many different conferences.
Hmm.
And it's pretty well known that going on a vegetarian diet can stop your PSA from rising and can even lower it.
Okay.
I just something to be aware of. There is a yearly test you can get for colon cancer that you just put a little poop in a tube and
Hmm.
that way you can be assured that you do not have obvious problems. Mostly they look for polyps, which they then remove. If you didn't have any, then they might not even want to do a colonoscopy when you're 81.
Well, I have a history of polyps, and I was actually on a shortened colonoscopy protocol, but this one has moved me out to 29, 5 years. But
Dr. Jeff,
I concur with your observation on red meat. I've cut out red meat completely, and I've been talking to a uh, dietitian at Walter Reed about the right things to eat, and it's essentially what you were saying.
go ahead, Dr. Jeff.
Couple of questions. Do you have any diarrhea?
Um, Occasional.
And when you're bleeding, is the water in the bowl red, or you see a lot of blood on your stool?
It's as if the stool is wiping a clot off the side of the colon.
Yeah. Now, do you drink coffee, caffeinated coffee?
A cup a day.
Okay. And spicy foods? Do you like to eat spicy foods?
Occasionally, I don't eat that much.
And any alcohol ingestion?
2 drinks a week. I'm trying to limit, and I've got it down to about 2 drinks a week. And I know those are all bad.
They
Is
are.
that they are
Yeah.
factors for the proctitis?
For inflammation, yes.
Okay.
Yeah,
All right.
decaf
Well,
coffee is fine. And one last thing, if the bleeding continues, make sure they keep an eye on your iron levels. Your hematocrit may not drop, but your iron levels can drop in it before your hematocrit drops. So they
okay.
can keep an eye on your iron levels. And, if you're bleeding and your blood count drops, you can get iron orally, you can get iron intramuscularly, you can get iron intravenously so that you don't become anemic. Because, I mean, I'm on this basically the same kind of drugs you are, and fatigue is not something we like to have, although I have it. And you don't want to get anemic on top of that, because that'll make you
Okay.
really wiped out.
Understood. Okay. Thank you.
Jeff, this is John. Could you clarify a little more about the caffeine? I'm not aware about caffeine and the pro-inflammatory. Did you mean in the GI tract or in general pro-inflammatory, or why caffeine?
Being ingested in the diet, uh, the foods that, because I had radiation colitis, and
Yeah.
the foods that they said to avoid, and I had diarrhea at the time too, was caffeinated coffees, caffeinated teas, spicy foods, alcohol, all the kind of stuff that, we avoid with ulcers. He's got an ulcer down below, not up top, but I mean, I drink decaf now,
Hmm.
Hmm.
and I have no more colitis, thank goodness.
The
And
dietitian
Jeff,
has told me that lycopene is a potentially significant factor, so I've started upping that with canned tomato sauce and tomato juice.
Dr. Jeff, is that okay with radiation colitis?
Well, I'll tell you, I supplement my lycopenes with goji berries,
Okay.
dried goji berries.
How do
You
you
eat
spell that?
like GOGI,
Okay.
like 15 to 20 a day.
Okay. Thank you.
They taste good, and they're rich with, they'll help your eyes too.
Okay.
We also think that exercise is associated with with a greater time to recurrence.
I have seen that several places and working that into my life also.
So I think to sort of wrap this up, and answer your key question is, how do I prevent recurrence and how do I know? Um, you really don't know, and you won't know um, until you come off of your hormone therapy, which is probably going to be sometime around the fourth quarter of this year, the end of the third quarter, the fourth quarter. I'm not aware of the 20 months, but I am, we're well aware that it's usually somewhere between 18 and 36 months, and nobody really knows. But we tend to think if it's at least 18 months and a little bit more, you're fine. So, and then you're going to have to wait for your PSA to rise,
Mhm.
and I don't know. We don't know how long that can be. What was your baseline testosterone level? Did you measure that?
It was reasonable for my age, a little low.
Okay.
Um,
Do you know
when I
what the
went in,
number was?
no, I don't.
Okay.
It
So
has been unmeasurable for since I
right.
started the.
So and it should be unmeasurable because that means the drugs are doing their job. But um, it could take a year or longer, 2 years, for your testosterone to recover, and you're just going to closely monitor your PSA. And the other thing that you're going to um, probably, I don't want to say probably, but you may experience is you may see a rise in your PSA and then a fall because the treatment you had can lead to a bump. And and that in my case, that's what I saw. My PSA went as high as 1.96 or 0.97, and then it dropped, and my Radonk said, oh, hang in, it'll go down, so don't get anxious if it does start to climb. But hopefully you'll keep coming back here, and we'll support you if that happens. Because that's why
I
we're here,
appreciate
because
that.
we have the experience. Do we have your email address?
I didn't put it in the,
Okay. If you want to send it to me in the chat, Rick Davis, directly, if you're not comfortable putting it in for everyone to see, we'll make sure you get entered on our database, and we'll put you in for this group, and we'll put you in for the veterans group. The veterans group is a terrific group that Captain Jim runs for us and
mhm.
helps people resolve all the issues they have about their benefits and their care. We don't talk about disease because it's open to everybody.
I'd
Okay.
like to make a little last comment too. You know, we often see when somebody's being managed by a general oncologist, we often see high risk people undertreated. But I would have to compliment Dr. Verma because for a non subspecialist, it seems like you've been very nicely aggressively treated, which is appropriate for a Gleason 9. So other than maybe overlooking the genetic testing, I think uh, you've had a nice aggressive treatment.
Well, the genetic testing was offered as part of a day-long prostate cancer orientation that National Military Medical Center Bethesda offers to newly diagnosed prostate cancer patients. I had let that slide and uh, just stepped back in to get the genetic testing done.
All right, guys, we're going to take one more comment from Peter, and then we're going to move on. Go ahead, Peter.
Yeah, I mean this is a little beyond the subject, but part of the subject. I just don't understand why things like Spacer or the gels are not considered um, standard of care for radiation. I mean, they've been around for years, and I'm not sure I understand what the controversy is about why to not use them when the possibility is there. I mean, it just seems to me like insurance, simple insurance without any side effects or downside. But what do I know?
Well, you could ask Mac, and he can give you the reason why he still doesn't use it. He didn't use it back in the day, and he's never used it. He doesn't like it. They are controversial. A lot of people use them. In a way, I wish he'd have used it when he treated me. I might have less problems right now, but not all radonks favor them. And I don't fully understand the reasoning. If anybody does, feel free to. Oh, Dr. Jeff, can you explain what the controversy is around the
It's
around the?
the size of the tumor. So they have a cutoff on the tumor size. And for instance, in my case, I had spread to the seminal vesicle and my tumor was fairly large. And they said, we can't cover your tumor with the Spacer gel. So we're not going to give it to you. If your tumor was smaller, they would have, but I wasn't a candidate because of size.
Okay.
Well, in Richard's case, his tumor was small on the millimeter level, and it was right up against the rectum. So I agree with Peter in this case. Probably would have been better to get it, but this is an academic discussion for Richard. It's
Right.
no point in looking back.
Yeah, I don't know if they do, you know, like urologists do. I don't know if radiation people have a standard of care review every few years or not, but I don't know. It's a mystery to me.
All right, Richard, thanks a lot. Come back next week and the week after as Rick invited you. and continued success. And I'm going to go to another Richard now in Virginia. Go ahead.
I just
You're
need,
muted.
yeah, I just had to unmute myself. Two real quick things. I'm now on the 14th round of cabazitol chemotherapy. 2 years ago, I had 6 rounds of doxil, but we're still going good. Still same kind of effects. And up at Johns Hopkins, they're saying, they've had people going 20 rounds before the side effects catch them.
Richard, was that cabazitaxel or docetaxel?
Originally, it was doxetaxel, and now this is the I don't pronounce these things with
Spell it.
Cabazitaxel.
Yeah, okay.
Cabazitaxel.
Cabazitaxel.
Cabazitaxel or Jevtana.
Yeah, Jevtana is the other name for it. So anyway, it's going good, and we'll see if I can beat the 20. The other thing, Dr. Allen has now got another patient who has the high-grade foamy gland cells. So there's 2 of us in Northern Virginia now.
Wow.
And that's all I have. And oh, by the way, all the scans are coming back. I never get in. I don't have anything on growth on any of the metastasis in the lungs. Nothing on the bones, and we just keep going. And
Terrific.
Nice response.
yeah, in other words, it's like no response right now. And and of course the testosterone remains around 5, and PSA is undetectable continually. So over more than 2 years. So far so good.
How are
How do
you
you tolerate
tolerating the cabazitaxel?
Fairly well. Fatigue is my biggest issue, and but it's the 3 weeks. The first couple of days, I feel great, and I also have the steroid going at the same time, and ADT. Um, so it's, but it bothers me, but not any more than anything else, I guess.
Are you exercising? Are you walking every day?
Not as much as I used to. I've got to admit, I need to do more.
I think you'll find that the more you exercise, I know it's counterintuitive, but the more you exercise and get out and walk, the less fatigue you're going to feel.
Yeah, I found that when I was a couple of weeks ago. But in the meantime, I've come down with, as you can tell, a cold and uh, a lot of coughing. So that's my excuse for the last 2 weeks now, trying to stay in and get over this.
Richard, can I ask you a quick question? I didn't hear it clearly. Did you say you're not showing a response to the treatment in your lungs and bones, or there's no visibility of pathology in your lung and bones any longer?
The bone scans come out, nothing new in the last a year at all, other than I cracked a rib falling, or two ribs falling. The CT, everything is just remaining the same. It's not growing, and it's not
Okay, got it. Thank you.
both in the prostate and in the lungs.
Gotcha.
Richard, are you on a bone strengthening drug?
Other than D3 and calcium.
And you
And then
didn't see.
I'm going again for the DEX scan end of next month.
Okay, good.
And then they've threatened me with some of the drugs. I don't remember what they are, but otherwise, and I keep on saying, for somebody who's supposedly as sick as I am, I'm pretty healthy. I should have mentioned the neuropathy, but it's also worrisome at best, or worse.
I think we'll all be interested in hearing about your DEXA scan and the decision to go on a bone strengthening agent after that.
Yeah, that is all happening within a week with the next bone scan and the next CT scan. And the PSMA scan, I had that, but I never get PSA going up high enough for that to be too awfully useful. And they were going to do a biopsy on the lungs, but the good news and the bad news is they haven't grown big enough for the interventional radiologist to think he can hit them to get another biopsy. So it's good to be healthy. So we're going out to the West Coast in a couple of weeks.
Okay, Richard, we're going to move on.
Okay, that's all I
Thanks
had.
for the good report. Joel, you're up.
Okay, thank you, Len. I want to get back to an answer you gave 2 weeks ago at this meeting, and the subject is dormant prostate cancer. You said something to the effect of ADT does not kill the cancer, but it just puts it in dormancy. If that's a correct statement, my question is, and I've asked this question of many doctors up to now for the past 13 years, and it seems to me that ADT does kill some cancer and some cancer goes dormant. It did it for me. So I was wondering if I understood your statement correctly.
Yeah, I mean, I was merely repeating what I heard from both of my medical oncologists, Dr. O up at Mount Sinai, and down here, Dr. Elizabeth Guanchel in Sarasota. I wish I had followed up when I heard that from both of them, but like how established is that as a fact? So when I go back north, which will be in about 3 weeks, I'll ask Dr. O, and I'll let you know what he says.
Right?
That's
Okay.
what I heard as well, Len.
You heard that too, John?
Yeah.
Yeah.
Dr. John, you're saying that ADT doesn't kill cancer, it just puts it in dormancy. Is that what you're agreeing with?
Yes.
Okay, thank you.
Okay, to be continued. Now we'll go to Dr. Jack.
Okay, thank you. I've got this reverse osmosis filter I've been using for years, and and I've had the same filter. One of them I have to change every 3 years. And I went to look at it today, and I realized I've had this filter that not only allows me to drink water that's less acidic, but it also adds calcium to the water. And I'm trying to understand how much calcium would be beneficial to preventing osteoporosis, osteopenia, and how much would be detrimental to potentiating metastatic bone disease, which I have. And I'd like to understand a little more about, how do you really strike a balance between those two situations, whereby I want to take enough calcium to minimize my chances of getting osteoporosis, but I don't want to take too much and end up, getting more metastases than I would get if I wouldn't take this calcium. So is there anybody who can help me understand this balance?
It's a tough one. Anybody have an answer for that? John, go ahead.
I think the answer to that is to have about 1,200 milligrams of calcium a day in order to help your bones, but don't go up to 2 grams a day because there is some association with cancer recurrence.
Where does that association come from? I was reading a Mayo study today, and it said it's still up in the air. You shouldn't do too much, but they don't know exactly how much. Where'd you get the 2,000 from, John?
I heard it from a talk a while ago, and I will try to research it for you, and I'll send you an email, okay?
Thanks, John. Yeah, it's hard to measure when, I get up in the morning, I have my whey protein shake with some yogurt, a ton of yogurt, and then I have almond milk every day, and that's about the extent of obvious calcium I have during the day other than vegetables and fish and stuff that, like salmon and tuna and stuff. But I just wonder how you can really measure the amount of calcium you ingest. My supplements don't have calcium. They have everything else, but not, so I don't supplement with calcium. But I'm just wondering how you measure out 1,200, 13, less than 2,000.
You just look up on a table. If you have 3 ounces of salmon, you look up and see how much calcium there is in it.
Look at all
What's more difficult to figure out, to me, is what your water purification system leaves in the water.
Yeah, that's difficult. I think I'm going to err on the side of caution with that and get rid of that filter and go back to the old filter without the calcium addition. So I just wanted to, check it out with you guys because you've been around this disease longer than I.
Well, what
Okay.
about just relying on your blood calcium level? Would that be a fairly reasonable approach or no? Anybody know?
I don't think so, Len, because of the homeostatic mechanisms in the body. If we take excess calcium, our blood calcium level will not change much, but we're still exposing ourselves to a lot of calcium.
Yeah,
Okay.
Len, there are many people who have osteoporosis and have normal blood calciums. Your body does everything it can to keep your blood calcium normal, either robbing it from the bones, or if you take in too much, sticking it in your bones with hormones, parathormone, calcitonin. They regulate that very carefully, as John said.
Okay. That's why it's good to have MDs on the call. Thank you, guys.
I have a related question.
But hold on, Larry, because I have a couple of guys with questions before you.
Okay.
But we'll get to you. Jim Marshall, you go ahead.
John, I believe it is on the 1,200. It should be split into 2 600s, not the 1,200 at a crack.
I
The way
agree
I
with you.
understand
I don't think we're capable of absorbing more than 500 or 600 milligrams of calcium in one go.
it.
So I agree.
Right. Um, Then there's another issue. I know of some folks where calcium will cause the kidney stones. So they have to be extremely careful on the calcium side. That's it.
All right. Dr. Jeff, your hand was up. Did you already make your comment or do you have something else for us?
Jack, a really good source of calcium in the diet is fortified orange juice. 1 glass, 8 ounces of calcium fortified orange juice is about 400 milligrams. So that is often neglected as a dietary source of calcium. And given a choice, I would take calcium citrate over calcium carbonate for absorption, better with citrate, and of course take vitamin D in association with the calcium.
Jack, you muted.
Citrium, you're talking citrate as orange juice you're talking about rather than a supplement?
Oh, yeah, if you want if you want calcium in your diet, fortified orange juice.
I see.
Some of the juices don't have calcium added, other ones have calcium added. So I would, if you want it in the diet, get fortified orange juice. And I don't know if you like sardines with bones, but it's another great source.
I know.
Sardines with the bones in is another great source of calcium.
I think I get enough calcium. I'm concerned about getting too much. Thank you, Jeff.
And the calcium
Great.
citrate he mentioned, Jack, was for supplements. You
Yeah.
can take them on an empty stomach, whereas calcium carbonate you have to take with food.
Right.
Also, calcium carbonate can be constipating. All right, Larry Fish, go ahead.
Wow, what a timely conversation this is turning out to be for me. So, my last doctor visit, going through my meds and prefacing this with this story, that I've been taking, my vitamin D had been low, and I've been on like once a week a 50,000 IU pill. And my doctor asked me, "Are you also taking calcium?" I said, "Well, I take 600 once a week along with the vitamin D." And doctor said, "Maybe you should add another once or twice a week, another 600 calcium." And I started actually increasing my intake of milk and kefir and bones, been making, and so I increased my calcium intake that way. I had a blood test result today that showed that the first time in my life my calcium was high, and I thought, oh, I better cut back. And my question, maybe I should cut back a little. And my question was, is there an association between high blood calcium and increased cancer risk or prostate cancer risk? Or is it just having too much in your diet? Or is there actual
Yeah, the answer is yes, there is. There is there's an association. Studies have been done that show that if you have high calcium levels in your blood, you're more likely to have aggressive prostate cancer. And I found that out many years ago when I was diagnosed, because I've always had high calcium levels in my blood, and I was osteoporotic, and I was diagnosed 4+4. And I can't give you the reference because I haven't thought about it for a long time, but there is an association.
very interesting to me. I didn't really worry about calcium because I haven't reached osteopenia yet, although I'm on a couple of ADTs. Um, but now this is the first time I noticed, oh, look, your blood calcium is high. What does that mean? I think it means I have to stop taking calcium supplements and cut back a little on the amount of milk and kefir and bone in my diet, and I was just thinking maybe that's a good idea if your
Well,
calcium is high.
I mean, I think we'd all suggest that too much dairy in your diet is not good for prostate cancer. That we know.
Because of the
So
calcium or because of the fat?
I don't know, but we do. I don't know the reason. Somebody on the call might do, but I do know that uh, they they recommend dairy and red meat as the two things that you cut out first. And I went for a long time without the dairy, without cheese. Now I eat a moderate amount of cheese, not a lot, but I think we should all be sensitive to the amount of dairy we take in. Interestingly enough, low fat and skim milk is as bad as high fat milk. So it's something in the protein that's the problem as opposed to the fat in the milk. And you can follow up with some of the almost all the nutrition documents that we have on our site and the videos. They all recommend you cut back on dairy.
Well, it could be the hormones also, you know.
Yeah, I tend to agree with you, Dr. Jeff.
A lot of hormones in animal products, and you know, that's why I drink almond milk.
All right. I've been asked to make sure you all know that the chat box can be accessed in the top right corner of your screen, next to the little symbol of a person with the number 33, which is the number of participants we have right now. So you just click on that little chat box, just like a speech bubble. And right now you'll find that Jim Marshall's going to have to give up ice cream now. Sorry, Jim, if you look in the chat. But also Tony Fig posted a link to an article on calcium connection with AFib. All right, I've done my duty there. And I'm going to go to Tom Matika. Go ahead, Tom.
Yeah, hi. Yeah, I'm here. I haven't given an update. I don't even know if I've ever given an
Tom,
update. Yeah.
could you raise the volume a bit or get closer to the mic? Maybe it's just me, but I can barely hear you.
Okay. How's that? Is that better?
Much better. Thank you.
Okay. All right. Yeah. Okay. Very good. Anyway, I'm not exactly sure how I want to go about doing this, but I think I just want to say for right now, just my status as to what I'm doing right now. And I have finally transferred to an oncologist at OHSU, Dr. Sokolova. I've only had one meeting with her, and so I don't have too much to say about her or her skills. I didn't really ask her directly if she was a GU oncologist. I forgot to do that. But, she comes fairly well recommended by the group here. So I decided to go over to her. And I'm only on a monotherapy of Degarelix, Firmagon. That's all I've ever taken since I've been on ADT, which was from about October. And my PSA was rising, doubling every 2 months before the October time. When I got on the Firmagon, it just dropped right down to 0.07, the first treatment, then 0.03, 0.01, and it stayed at 0.01 for the next couple of treatments. And my last lab that I had done at OHSU, my PSA was 0.05. And so, I looked at that and I thought, oh my God, my PSA has quintupled, in 1 month. But, I'm not sure what the significance of that is, but she didn't say anything about it during my visit. And I've asked and through the MyChart communication system, and they said it's nothing to really be too alarmed about. So I don't want to be alarmed about it. And what we're doing is I'm trying to start a second ADT, but there's a lot of just a lot of bureaucratic uh, involvement with the insurance companies, and I want to know how much I'm going to have to pay for this. So it's kind of a slow process of doing that. I've gotten an approval for abiraterone and enzalutamide from my first oncologist, and they approved that. So I've got those approvals, but they say it's good till the end of the year. But after listening to the group for several months, uh, I thought, well, for me, and because of the side effects of the abiraterone, although I hear people taking it, I mean, people are taking it and they're well satisfied with it because of the heart issues, the liver issues. Okay, I mean, it's just sort of a academic thing for me, but I thought, well, maybe it's better for me to do the darolutamide too, because in the last couple of months here, people have just been praising darolutamide. Those side effects are not as pronounced with the darolutamide, except it's except it's a lot more expensive. And I don't have an approval on that one. I got a letter. They said they denied that, and that's in process now as to whether or not the drug company will approve the darolutamide. Then I'm going to have to choose to do one of those. And I think if nothing else, I'm going to do the abiraterone and just continue with that. Money is a big issue for me, and I'm hoping I can make it through this year. If the abiraterone is relatively inexpensive, it's about $130 a month with my United Healthcare insurance, I think.
Yeah.
And so if I make it through to 2025, I think that then Medicare is going to cap the out-of-pocket costs at $2,000, if I understand that correctly, which I'm not sure I do, but that's how it sounds. So the max out-of-pocket will be $2,000, and that'll be a lot better than, I think the current cap is $8,000, although I do understand that you don't end up really paying that much out of pocket, for a year. And
Tom,
yes.
Could you remind me again, what is your status with regard to metastasis? Apparently, you're still hormone sensitive. They generally don't consider you to be hormone insensitive or resistant unless you have 3 consecutive rises in your PSA on an ADT drug. You've only had one, if I understand correctly, which could be an aberration. So what?
Right.
Tell me, what is your? I'm trying to figure out if you're eligible for darolutamide, and I kind of doubt it, but go ahead.
Okay. Well, since October, my PSA went to my PSA was 85. First treatment of Degarelix went down to 0.07. Next treatment 0.03. The next treatment 0.01, and it has stayed that way for the next next couple of treatments until this last treatment at OHSU. So right now it reads 0.05.
And do you have any metastases?
I do have bone metastases in my ilium and sacrum, and they're fairly good size. I can't give you the exact
Yeah,
size
that's all right.
of it.
Well, yeah, I mean, I was hormone sensitive and metastatic when I was prescribed darolutamide, and I believe Peter was as well. So it's possible you could get it, but technically you're supposed to be castrate resistant and metastatic.
Oh, castrate resistant.
Or
Okay.
actually non-metastatic. It was a weird approval for darolutamide. Go ahead, Peter.
Yeah, Tom.
Yes.
Write down my email. It's simple. It's Peter K. at AnCan.org. Send me an email and I'll send you the number for the Bayer Patient Assistance Program,
Okay.
and you get the paperwork and fill it out. I think they want your tax return, and and they can. So they provided darolutamide for free for me for 3 years. You'll have a form that you have to give to the doctor, but it might be a way to just run it around. It doesn't even go through insurance, so they might be able, Bayer itself might be able to help you out. But send me an
Okay.
email and I'll respond to you.
Okay,
That
I'll do
works
that,
for
Peter.
me too.
Dr. Jeff, go ahead.
So for me, as a summary, back in July, I was diagnosed with a Gleason 9. I had a PSMA scan, and that was clear. There were no mets. There was spread to the seminal vesicle only. I was initially on Firmagon every month, too painful. I'm now on Eligard Q6 months, abiraterone a gram a day, prednisone 10 milligrams a day, Prolia injections for osteoporosis, which I had prior to starting the ADT. I do take calcium. I do take vitamin D. I finished 48 external beam radiation treatments on December the 8th. I had a PSA done on Saturday, which was 0.02, and the previous one had been 0.18, and I started with a PSA of 9. So I saw my urologist today who was satisfied with the direction, and I asked him basically the same question that Richard asked before, and I said, so the plan is I'm going to finish 2 years, so I have 16 more months left of Eligard and abiraterone and prednisone, and then as Rick said, they're going to stop the treatment and they're going to watch my PSA, which is kind of, it's kind of whack-a-mole kind of stuff where, we'll do this, we'll stop, we'll see where you are. So he did say, though, he said, you know what, I'll do another PSMA PET scan for you when you're off this for about a month, and let's see. My first scan was clean. Let's see what's happening currently. So that's just an update. I'm pretty satisfied with the chemical results. I plod along with being tired. I try to exercise every day, but some days I'm really so wiped out that I just can't do it. So I have to pass on the walking for that day. But I don't give up. The next day, if I feel better, then I go ahead and do my mile and a half, 2 mile walk.
All right, Jack, when I called on you, it was because you had your hand raised, and I thought you had a question or comment for.
Well, the guy left. The gentleman left who I did,
well,
but he
I know
left.
you wanted to talk tonight, but you kind of hijacked.
I just finished.
Okay, and so Rick, you had something. You had your hand raised. You're muted.
Let's go back to Tom Matika. I'm sorry, Tom, that we lost you there.
I'm still here.
He's still here.
If it turns out that you go on abiraterone, then there is an accepted protocol with abiraterone where you take a quarter dose with food every day. And if you are on a budget, that is a very, very good way to extend the abiraterone. And so it becomes a lot less expensive as opposed to taking 1,000 milligrams a day, you take 250. And you should be aware of that because that could help your pocketbook very significantly. So when you say it's $100, if that's a month, or 125, whatever you said, if that's based on 1,000 milligrams a day for the month, then you could turn that into $100 or $125 for 4 months. So just be aware of that and talk to Dr. Sokolova. Dr. Sokolova is a GU medical oncologist.
Okay.
And talk to Dr. Sokolova about using that protocol, because you want to save money. And I'm sure she'll endorse it. She'll understand it. She'll endorse it. We haven't seen any inferior results with people taking a lower dose with food. And the reason it works right now, if you're taking 1,000 milligrams, you have to take it early in the morning, and you have to wait an hour, I think it is, or an hour and a half. The guys will tell you who are on it before you eat, because the abiraterone is processed through the liver. So if you take a smaller dose and it gets processed through the liver with food, you can manage on less abiraterone. Does that make sense to you?
Well, it does. It does make sense, yeah. And the approval that I got, they're calling out, and I think she probably put this in. Dr. Sokolova put this in. The tabs are 250 milligram tabs. Does that make
That's
any
right.
difference?
Yes, but you take 4 of them.
Oh,
And what we're saying is, instead of taking 4 of them, you only need to take 1 of them a day. Instead of taking
okay.
4 a day, you only need to, so they last 4 times as long.
I understand. Yeah, yeah.
Okay.
Cost-wise, the abiraterone is not a too big of a burden for me. If the cost is, as they told me, about $130 a month, that's manageable. But I think the darolutamide doesn't. I mean, I'm not sure if it's going to get approved, but that's I don't know what that is. 600, 1,000,
Well,
2,000.
don't get ahead of yourself.
Yeah, right.
Be in touch with Peter Kafka or Dr. John, and let's see if Bayer still has a program. I'm not sure that they still do. I know they did. Somewhere in my mind, I'm hearing, I'm thinking that they may not run the program, but they may have some. They may have some supplement. Well, I know that when they first started, they used to give it out free to everybody. Now
Rick,
they may just have a program.
Rick, I just started on darolutamide 3 months ago, and Bayer is supplying me for the whole year.
Okay, thank you for that, Jerry. So there you go. There's the answer. Does anybody have anything else before we move back to Dr. Jeff?
Thanks, Jerry.
Anybody have anything else for Tom Matika before we move back to Dr. Jeff? Okay. So Dr.
All right.
Jeff, the reason why we don't like the 45 milligram shot is because we've seen that it's not consistent at the back end, and in some men it can wear off early. So it's not a solid control in the latter part of the 5th and sometimes the 6th month. So we strongly advise against a 6-month shot here. We suggest either a 3-month or a 4-month shot. So that's the reason why, and we've seen it. I mean, we've seen it more than once, where people, men, see weird things happening with their testosterone and PSA in that 6th month.
Good to know. I don't mind 3 months. It's a painless injection. The Firmagon I got off because it was just too painful.
Right. Well, we'd suggest to you, if you can get it, to get on the Orgovix, to be honest, because we think it's a better drug. we are fairly certain that it stops the testosterone much quicker, and the recovery of testosterone is much quicker. And there are guys on this call who will attest to that, in this group who will attest to that. So the ideal at this point is, if your insurance will pay for it, is to be on the Orgovix.
Yeah, they probably will, but I get the point of wanting, when you get off this stuff, to have your testosterone rebound faster. The more I hear about this, maybe it's not a great idea to have your testosterone rebound faster, since with an undetectable testosterone, my PSA is so low. So maybe I'm living
Well,
okay.
no. Well, no. I think you're fooling yourself with that argument. What you want to be is undetectable with normal testosterone, right? We can agree on that, right?
Correct.
So the quicker your testosterone comes back, the quicker you know whether your treatment has succeeded or failed. To say, well, may as well wait as long as we can and we'll see what happens when the testosterone comes back, that's not helping you in the treatment of your disease. And the cancer could be growing and you wouldn't even know.
Well, as I
Because it's
said,
not registered, because it's being kept. It sort of gets us back into that dormancy discussion. To me, what we would ideally like to see, or I would like to see, is I'd like to see my testosterone come back as quickly as possible, and then have a true reading of my PSA.
Well, I think his plan was, though, to give me another scan around that time. But I hear your point.
Oh, for sure you'll get another scan, but the scan may not show what a testosterone is going to show, because the testosterone is going to help bring out if there is micrometastasis. We hope there isn't, whereas the scan won't see it. So the best thing is, let's get the testosterone back up to a normal level, because that's going to make PSA a good marker. As good as the scan, maybe not as good as the scan, but probably better than a scan at very low levels where we're not going to see anything.
Well, we've got Dennis Correa up on deck. Go ahead, Dennis.
Yeah, I've been having more leg muscle stiffness, particularly when I get up in the morning. I got to stand there, and it almost feels like my knees or my hip or my foot's going to collapse. And wondering if it might be related to the Prolia that I started back in February after getting my DEXA scan, where I did have a low density in the left femur. In the left side does seem a little bit more prone to this weakness, stiffness than the right side. No upper body muscle stiffness or anything. It's like from the hips down. And also fatigue sets in a lot earlier now from the standpoint of having any kind of endurance. I don't last so very, very long. I can't do my walks as far as I used to. I walk around a block and that's about it. And so I'm not sure if it's, next year I'll be 80. So I'm wondering, the age part of it. And, but that was the only real, I am on the drug holiday right now. Started back in August was my last Eligard, and actually stopped the Abby and prednisone in October. So just kind of wondering if anybody else has been dealing with that. It kind of reminds me of when I first got the chemo, how my legs felt real heavy and so on when I would get up from sitting or out of bed in the morning. But the cramping, I use that TheraWorks, and that usually solved the problem. But sometimes I was going for quite a while without having any cramping. And then when I go out and I do something a little bit different, like I was doing some stuff around the house where I had to stand on a ladder for a while, and I don't know if that did something, but I'll get the leg cramps at night in the calves, or my foot will start to like twist, and usually I can get up out of bed right away and try to stand on it, stretch it out, put the TheraWorks on. But what I found does work pretty good for me is the Epsom salts. I'll take a warm hot bath with some Epsom salts before I go to bed, and then I stretch my calf muscles, and the ankle muscles, and so on, and that seems to be helping a little bit. But just kind of wondering if anybody else is having it. Anybody else got any suggestions?
I got the side effect list up here, and it does list muscle cramps in the legs, muscle stiffness, and unusual tiredness or weakness.
There you go. That's kind of what I suspected. I had looked at it a while back before I started it, and I thought I remembered that was in there.
Dennis, did
how
your
long have you been on
testosterone
it?
ever recover?
Pardon?
Did your testosterone ever recover?
No.
That's part of
Never
it
come
too.
back to- Yeah, that's it. I know that was the same deal when I took the holiday last time. I got up to about 8 months, and my PSA was rising pretty fast at that point, and never got the testosterone above less than 12.
That's part of it too. That's what's affected me.
Yeah, I figured that all of these things together probably contributing to it. So I guess I could deal with it. That's the way it is. I mean, uh, I think I'm going to stay with the Prolia, at least from my last DEXA scan. That's what was recommended because of that one spot in my left femur that was low.
Well, there is. You might want to discuss this with your doc. A bone strengthener is probably very appropriate. But there are other bisphosphonates other than Prolia that you might be able to use, and you can try them and see if you do better on them. I mean, certainly Zometa, which is an infusion, and you can take it every 3 months, say, and see if that does better than the denosumab. There's I can't remember what it's called. Activa, is it? There is there's Fosamax, but that's, you don't want to deal with that because that's a daily pill, and you've got to be upright and God knows what before. But there's a weekly version of Fosamax, and I think that there's a 6 monthly version of Fosamax. Do any of the guys or the docs on the call know what that one's called? I can't remember it. The 6 month injection of bisphosphonate.
That's
But
what my Prolia is, 6 months injection.
yeah, Prolia is a 6 month injection of denosumab, but I'm pretty sure there is also a 6 month injection for a bisphosphonate. But I'm if I can find it, I'll tell you. But I think there is one. But you might want to just talk to Singh about an alternative to denosumab because you're not doing well on it.
You mean Zometa, Rick?
No, Zometa is an infusion, and
Yeah.
they can give it. I mean, they can give. I got it yearly. They originally used to give it every 6 weeks, which was kind of crazy. And
Yeah.
then they decided no, it should really be given every 3 months. So that's why I say you could get a 3 month Zometa infusion. It's about 40 minutes. It's not a huge deal. But I seem to think that there is another formulation, but I could be wrong. I thought there was another formulation of that bisphosphonate that was in a longer format, either 3 or 6 months, other than the Zometa infusion. But that's what I would be discussing, Dennis, because you
Okay.
may just be responding badly to the denosumab, and you wouldn't respond so badly to zoledronic acid or another bisphosphonate.
Yeah. And then my
And it's,
PSA seems to be creeping up. Back in October, it was 0.03, still non-detected if you look at less than 0.1. And then December was up to 0.08. And then the last one I had in January was 0.13.
Mm-hmm.
Yeah,
Mm-hmm.
I can come
So
back.
that, I mean, the PSA seems to be rising. I don't know. It could stop at some point here and just stay stable, but I'm not concerned about it at this point. But just another side element here.
Creeping up.
yeah, you might want to get a scan when it gets to about 0.2. How long
Well,
were you on Prolia?
the Prolia started in February,
Oh, you
middle of February.
just started it. Okay. Yeah, I think Peter's on the right track there. If your T level is still hasn't recovered, you're 80 years old. Uh, you know, these could all be reasons why your bones are creaking and you're feeling tired. And
Right. Yeah. Yeah. Can't do what I used to do. That's for sure. I haven't played golf in over a year,
Uh,
so I'm thinking about it. I'll try out, see if I could go to the range, hit a few balls, see what happens. If no parts fall off, I'll try a 9-hole group, see what happens. But just like
I'll
an
go
old
with you next time I'm down there.
I feel
all right,
exactly
Dennis.
Dennis.
thing.
Dennis, when is that DEXA scan coming up?
I just had one. The
Oh,
last,
and
yeah, I just had a DEXA scan
It's the first one I
in
ever
January, and before that it was 2 years. So been doing a DEXA scan every 2 years, and that showed a minus 1.7 my left femoral neck. And the recommendation was because of the high risk, because of the prostate cancer and so on, they recommended starting a drug for bone
right.
strengthening.
Okay.
Is good old-fashioned calcitonin ever used anymore?
What is it, John?
Calcitonin. Do you know, Jeff? That ever is that still around? I mean, as an alternate for bones. I'll have to check it out.
I know calcitonin gene-related peptide is a treatment for migraine, but I never heard of it in any other context.
Hmm.
Calcitonin will put excess calcium, you're right, into your bones. It's the opposing hormone to parathyroid hormone.
Mm-hmm.
So, yeah, it will drive calcium into the bones.
I
And
never
do you know if
heard
they
any
still
of our
use it,
guys
Jeff?
ever being on it, though.
Jeff, do they still use it?
So I don't think it's used. I've seen it used to treat Paget's disease of the bone. Uh, I've seen it in patients who have hypercalcemia. Um, And
I
I
think
used to see it
osteopenia.
with postmenopausal women with osteoporosis.
Yeah.
I don't know if they use it in, men with prostate cancer, though.
You mentioned parathyroid. Is that something that could be indicated here too? Is there an easy test for that, or to see if that's functioning properly?
Yeah,
Yeah,
there's a
it's
blood
blood
test,
test
sure.
for that.
And Dennis, the shot that I was thinking of is Boniva. That's the trade name, Boniva, and
Yeah.
it is another bisphosphonate. And I think it's every 6 months. So instead of getting a Prolia shot, you could get a Boniva shot. I put it in the chat window for you.
Thank you, Rick.
That was the
Yeah.
drug I was trying to think of, Boniva.
Yeah. Good.
That's IV also, I think.
I think it's a shot. I'm pretty sure it's a shot, Dr. John.
Okay.
I mean, it may be available as an infusion too, but
Mm.
I'm pretty sure that it can be given. It comes in two forms. It comes in tablets, and I think the other is. I think it comes in tablets, and I don't know how often you'd have to take the tablets, and whether you'd have the same issue as Fosamax, where you have to take it and then stay upright, and you can't eat for a while, and have to take them in the morning and get up early. I don't know. You'd have to ask them. And I think the other version is as a shot, but I'm not certain.
I think Boniva's once a month, a tablet.
Could be. Yeah, I think you're right. I think it's once a month tablet or a shot, which is every 6 months. I think it's a once a month tablet. I think you're right, Dr. Jeff.
Yeah, I think my wife took that for a while before. She had problems with it, causing her gastric distress and stuff.
But the
Jim
point,
Marshall, go ahead.
Dennis, how are you at hydration? Because if I don't
I
drink
realize that's another
at night,
factor.
the legs
I do drink a lot of water. Occasionally I might slip behind a little bit and just forget to keep drinking, When it cools down here in Arizona, I just don't feel like drinking quite as much. I got to think about it. Whereas as the weather warms up, I don't have to think about it. I'm hitting the water, all day long. I've just started, when I was playing golf and I was playing throughout, the summers here, I was using Pedialyte. And so I've got Pedialyte, and I've just started today using some Pedialyte to see if that helps with the hydration too.
Good.
Jeff Markey, go ahead.
I've been on Fosamax for a long time, and I get these email from Dr. Michael Greger, about it once a week, maybe even more often. And he had one a couple of months ago about the fact that Fosamax is pretty much ineffective when it comes to hip fractures. And it really is very little effectiveness at all. In fact, just as a side, Dr. Hartstark, I spoke to her about a week ago, and she said, "Oh, she was going to put me in on Xgeva. I'm having my knee replaced in Monday, and she said she's going to have me move to Xgeva as soon as I've recovered from that." But another one is Dr. Greger. Just now, I'm looking at my mail, and he's got this: how rare are biphosphonate class of our osteoporosis drugs devastating side effects, which ironically include bone fractures. So the Fosamax has some interesting issues. And he had a 6-minute video about how ineffective it was about 2 or 3 months ago. And here now he talks about how it can cause bone fractures. But that's...
Well, I think we generally think today that denosumab is a better drug than a bisphosphonate.
Yeah.
But the question is how you tolerate it. So if you don't tolerate the denosumab that well, it's probably worth trying a bisphosphonate. And the reason why they work in different ways, and probably Dr. Jeff can explain the different ways, but they work in different ways. But the way that the bisphosphonates work is they make your bones denser. They are I have to get this right, but they're osteoblasts, I think, and they fill in the holes. And what happens is that your bones become denser, but they become more brittle. And because they become more brittle, you're more likely to get a fracture. So on the one hand, they fill the bones in so that the gaps aren't there to fracture. But on the other hand, if you get a big jolt, then there isn't the flexibility left in the bone to absorb it, and it tends to crack. That's why the Fosamax, which is a bisphosphonate, may result in more fractures than, say, the denosumab.
I've heard that you can get the most denosumab every 3 months for some people, and it works just as well as the monthly shots.
Yeah, that's
Well,
pretty much the way they dose it now. 3 months. I've never heard of anybody getting it every month, even though that's the way it was approved. They're concerned, of course, about bone necrosis in the jaw.
every 6 weeks. I thought the approval was every 6 weeks. No, was it every month or was it every 6 weeks?
Pretty sure it was every month, but
Okay.
everybody, all the med oncs give it once every 3 months.
Okay.
Yeah, I get mine every 6 months. Prolia.
Well, that's Prolia?
Yeah.
No, I'm talking about Xgeva.
Oh, all right. Okay. Thought you were talking about denosumab.
Yeah,
Well, we are.
They're both denosumab, but Prolia is 60 milligrams and Xgeva is 120 milligrams. So you're actually getting quite like a quadruple the dose when you take Xgeva, if you're taking it every 3 months. Anyway, let us move on to Frank Fabish.
I started on Pluvicto. I had my first treatment a week and a half ago. I will be going in for a 3-week blood draw because my doc wants to monitor my numbers, especially after the first treatment. The side effects I've had from it so far have been muscle fatigue and dry mouth are the two most pronounced side effects. But I've also had two strange ones that I haven't heard somebody talk about before. One is it tends to enhance my taste. The flavors tend to be more flavorful than before. Typically, it goes the other way, that you either get a different taste or no taste at all. But I've found that it does that. The second thing that I found is that when I wake up in the middle of the night, I can't get back to sleep. And I was surprised by that. So I have to pick it up by picking up a nap somewhere later in the morning or early afternoon. But I'm on every 6 weeks on the infusion, and I already have the 6-month schedule, and I'll have my last treatment, if everything works okay, I'll have it on October the 3rd. So that's my update.
So Jim Barnes, you have any of those experiences like Frank is talking about?
Yes, certainly the dry mouth. As far as getting up every night, it's my sleep's so erratic on all the medications that I've been on. But I usually get back to sleep pretty easily, so I haven't had a wake up where I can't get back to sleep. And that's funny you mentioned food. I really didn't think about it consciously, but you may be right because there's times I have just sat down at a meal and just everything tastes amazing, and it's so good to be able to eat without vomiting or anything like that because I haven't had any nausea or anything like that with the lutetium shots that I've had. So I would say that my experiences were consistent with yours, Frank, with the exception of getting up in the middle of the night and not being able to go back to sleep.
Go ahead, Rick.
Frank, did you check with your doc whether your PSMA scan was concordant with the scan you got about 8 weeks ago, or 8 weeks ago when we last spoke? You're muted. You're muted, Frank. Unmute.
Pardon me. Yes, I did check with him, and he said the same thing that was said when we talked about it. Is it's in the definition of the scan as the FTG versus the CT scans with contrast. And but he's prepared if the Pluvicto is not effective, is to conduct more scans and delve into it deeper. I'm hoping it doesn't come to that. I'm hoping that the Pluvicto will impact me positively.
Right. So let me just understand. So you did get an FDG CT scan several weeks ago.
Yes.
And was that scan concordant with the recent PSMA scan? Did the same lesions that showed up on that FDG PET scan show up on the PSMA, or were there some on the FDG CT scan that did not show up on the PSMA?
No, they were identical. And
Fantastic. Okay, great.
And he's focusing everything on the nodules in the lungs because that's what showed up on all the scans, and that's in line with 2 years of history as we've been dealing with.
One of those studies, it might have been one of the studies Len pointed out that we talked about, suggested that lung metastases have the best prognosis. I can think of one person that was definitely true, which was my good buddy Jerry. Jerry Deans, who had lung mets very early on and lived for another 18 years after they saw the lung mets. I think they first saw those lung mets in Jerry Deans in about 2004, and he passed away in June of 22. So, maybe there is something to the fact that the lung mets have the best prognosis.
Well, I'm hoping and praying that will continue.
Okay.
Give me lung mets.
There you go.
I would say give me no mets, but
Yeah.
since I have it, that's better than the others.
Apparently. Well, let's see. You said we had someone else who is new, because I've gone through the list now, Rick. Is that person still with us?
Yes. Peter, do you want to briefly introduce Mr. Cross?
Sure. Matthew Cross is on with us, and He's he was referred to me through Jim Schrate. He lives in Chicago, and I'm not going to. I'll let him speak for himself. He has not had primary treatment yet, other than ADT and Zytiga, abiraterone. Um, he's not had, but he's like me. He's going into this with urinary retention and being on a catheter, which is a drag. He's been on for quite some time, longer than I was on for 8 months, and he's still dealing with it, which will probably preclude doing radiation. I know when I was diagnosed, the radiation docs wouldn't talk to me because I was on a catheter, and they felt it would make it worse. So he's in the Chicago area, and he does not have a medical oncologist yet, and he might need to find a really good surgeon too, if that's the way he needs to go. He's 70 years old, and so I'll let Matthew speak for himself. If you unmute yourself, Matt, you can introduce yourself. Or Rick, maybe you can speak to good doctors in the Chicago area.
Are you there, Matthew? Would you like to speak up? You need to take yourself off of mute. So there's going to be a little microphone in the bottom of the screen. Click on that and it'll unmute you. So
Is he on the phone?
I can't tell.
No, I don't think so. No, because nobody filled in a name. So maybe there's also a chat window, Matthew. The 2 little squares at the top on the right, so you can, if you're having trouble, maybe you don't have a microphone. If that's the issue, then you can just speak to us through the chat window. I think that even up, if you could go and see.
Yes, can you hear me?
Now
Yes.
we can hear you. Yes.
All right. Okay. What were you saying?
Well, Len, go back to you, and then I'll.
Okay. So welcome, Matthew, and going to ask you a few questions. So see if we can help you out.
Yes, go right ahead.
So Peter told us you're 70 years old, and you're in the Chicago area, correct?
Yes.
And what was your Gleason score, and when were you diagnosed?
What was it, babe? 2019? Yeah. 2019.
Okay. Do you remember your Gleason score?
8.
4 plus 4?
Yes.
Okay, so that's over 4 years ago. All they've done is put you on hormone therapy and all that time?
Correct. Yeah, abiraterone, and I take a Leuprod shot and abiraterone with prednisone.
Right. Okay.
But though, excuse me, I wanted to just let you know that I was off of it for a while there. So
Okay. And so did you get to an undetectable level when they took you off?
you mean the PSA?
PSA, yeah.
No, it wasn't.
Okay. Do you remember what it was?
241. It was at the beginning. It was 241. At the beginning, it was 290.
All right. And then the drugs took it down to what?
Took it down to 0.8.
And that's when you went on a drug holiday.
Yes.
And when was that? When did you go on holiday?
When you go on what?
Holiday.
Holiday for what?
Drug holiday.
Huh?
Drug holiday.
What's a drug holiday?
I went on there, I think it was in 2000.
You didn't take nothing in 23, if that's what you mean.
I don't have all that information on hand here.
Okay. So you for a while, you weren't taking any drugs. Then your PSA started rising again, I guess, and they put you back on the same drugs.
Yeah, that's right.
All right. And uh, did they ever talk to you about a prostatectomy or radiation as a therapy?
No, they didn't talk to me about that.
Because it's spread.
I didn't hear what your wife said. Because what?
You said something, I spread it.
Because it
Oh, it
spread.
spread.
Yeah,
Okay.
that was the old school of that is the old school of thinking that.
Yeah. Yeah. So was it in your bones, Matthew?
No, no.
Lymph nodes?
Yeah.
Okay. All right. So you're back on Abby or
Back on the Lupron
Lupron
and
and
the
Zytiga?
tamsulosin. Yeah.
Yeah. And now, do you know what your PSA is now?
I think it was 8.
Okay. Well, has it been coming down since you went back on the drugs?
Yeah.
Okay. And did you ever have any genetic testing?
I had a genetic testing, yeah, but we never. I don't know. You know,
It didn't come from no.
it wasn't from genetics.
It wasn't hereditary.
All right. So the purpose of your visit right now is to see if we can recommend a good GU medical oncologist. Is that right?
Sure.
Okay. So Rick, I guess we're going to turn to you for that info.
Pardon me?
So yeah, no, Len asked me if I could help out. So do you know what we mean by a GU medical oncologist?
No, not exactly.
Yeah, I didn't think so. So you need what type of doctor is looking after you right now? Is it a urologist or is it a medical oncologist?
It's a medical oncologist.
It is. Okay. One and where is their practice? Are they with a hospital or is it a practice or
University of Chicago.
so it's there you're in a University of Chicago facility and it's a general oncologist, is that right?
He's an oncologist, yeah.
General medical oncologist. So what we would suggest to you is to ask your oncologist for a referral within University of Chicago, staying at University of Chicago, to another doctor who specializes in prostate cancer.
Okay.
That's really what you want because things in prostate cancer move so quickly that it's hard for some of these general guys to stay up to date. And the reason Len was asking you about whether they've talked to you about surgery or radiation is because today we tend to treat the prostate even if it's spread. The old school of thinking, which your doctor is telling you, is do no harm, we don't treat the prostate if the disease is spread outside the prostate. But we know that if we do treat the prostate, men live longer.
I got
So
you.
the new school of thinking is we do treat the prostate. Now, for you, there are clearly other issues because you're catheterized. The question is, what is causing your blockage? Do you know what's causing the blockage and why you have to be catheterized?
No, not well. The medicine I was on and off of it for a while because I wasn't taking them. I had the abiraterone and the prednisone.
Yeah,
Okay.
but the aber when did you start having to catheterize? Was it after you started taking those drugs?
Say that again.
When did you start catheterizing? After you took the drugs?
Yes.
Sir, he ain't never even took no drugs.
So you're saying he started to catheterize before he took the abiraterone?
He won't even take any abiraterone or prednisone. He doesn't
Okay,
take any, he just takes the shot, and
okay,
that's
so
it.
he's not taking the other drugs?
No.
Okay, so why are you not taking the other drugs, Matthew?
I had reactions.
What reactions did you have?
Well, the abiraterone, I was losing. I was not focusing and stuff like that.
Well, that may not be the abiraterone. That could have been just from the Lupron. But the fact is, did you discuss that with your doctor?
Yeah.
And did the doctor say it's okay not to take the abiraterone?
Well, I was in like I wasn't taking it because I had an issue with foggy. You know, foggy, brain foggy.
I know we all know. Everybody in this group knows what you're talking about. Everybody.
So he
We've
don't
all
take
had
nothing. He
we've
doesn't
all
take
we've all had. Sorry, go ahead, ma'am.
I just wanted to let you know the truth that he doesn't take anything but the shot.
Okay, well,
And he
he,
will not take any other medicine, but he calls around asking about all kind of medicine and he's not gonna take anything.
well,
And you said
good for you.
radiation, they can't do any radiation until the tumors go down.
That's right. So the fact is, you can keep managing your disease. There's no point in me sending you to a really good doctor if you don't want to buy into the program.
That's right.
And if you don't want to buy into the program, the disease is going to get out of hand. It's going to get into your bones. You're going to be aching and moaning and groaning about that, and we're not going to be able to help you.
Mm-hmm.
So
Okay.
you can decide what you want to do, but if you want to, this disease may not kill you at all because we have so many ways to manage it today. We have so many different ways, but the only way we can manage it is with your help.
Right.
And if you don't want, if you're not interested in managing it, then there's not much point in us talking to you, you talking to a better doc, and what have you. We may well
Correct.
be able to get you to stop catheterizing if we can reduce the size of that uh, of those tumors that are in your prostate right now, which are closing off your ureter, so you can't
Right.
pee. That's the
Right.
problem. So we got to get them down, and the Lupron alone ain't doing it. So my suggestion to you, number one, is to get with the program. And then number two, if your doctor, what's the name of your doctor?
Doctor. Gee. Smolowitz.
Oh, you're with Dr. Smolowitz.
Yes.
Well, that's who we'd send you to. Have you told Dr. Smolowitz? He's one of the best doctors in the country. Now, have you told Dr. Smolowitz that you're not taking your drugs?
Yeah, I had discussed it and he told me that the Lupron, he said before that I could take a vacation on the Abiraterone.
That was a year ago.
What's your wife's name? We got to
My,
talk to her a
my
little bit
name
more.
my name is Kathy.
Kathy, when he goes to see Dr. Smolowitz, do you go with him?
Yes.
And do you talk to Dr. Smolowitz like you're talking to me when he says this
Yes.
bullshit?
Yes. And he always tell him to take the amiodarone and the prednisone. And Matthew always promises that he's gonna take it, but when he gets home, he hasn't taken that. He'll take one today, and 3 weeks later take one, and it's just. And then he worrying about the catheter. But how you gonna get off anything if you don't get with the program?
That's right. So I don't have another doctor to send you to because he's the best. He's the best in Chicago as far as we're concerned. We got other guys who are seeing him. I don't think anyone on the call right now, but we had a guy right before who loves him. We love Dr. Smolowitz,
Dr.
Dr.
Smother,
S.
great doctor.
We love him. And
Yeah.
the only thing that you can do is get with the program. And if you're having problems with brain fog, one thing you can talk to him about is a different drug. It's a drug called Nubeqa, Nubeqa, Nubeqa. And we've got some men, for example, who are just taking Nubeqa and not taking Lupron. And that might be an easier program for you, but you've got to get with the program. And we've got, what I should say is we've got men on Nubeqa who are Dr. Smolowitz's patients. And that's all
Okay.
they're taking. And you could have a discussion with Dr. Smolowitz, and if he may be willing to try and get you this Nubeqa and put you on that, so you don't get a Lupron shot and you don't take the abiraterone, all you take is the Nubeqa, and we can see how you do on that. But whatever
Okay.
happens, you've got to get with the program. So my recommendation would be to fess up with Dr. Smolowitz and tell him you're not taking it, and you can tell him that you met with the AnCan people. He knows who we are, and ask him about just taking Nubeqa on its own to help you with the brain fog.
Okay.
Anybody else? I've got other moderators on here. Anybody want to talk about this? Anyone else want to say anything to Matthew?
I was going to say the same thing, Rick. He should probably, the reason he's not taking abiraterone is because of brain fog. He should definitely ask Shmulowitz to put him on darolutamide monotherapy. You'll feel a lot better, Matthew, if you go on that drug.
What treatment are you? Hold on a minute, Matthew. What treatment are you on, Len?
I'm taking that drug. The trade name is Nubeqa, and the generic name is darolutamide. It's the same drug, just a different name.
Yeah, let's just call it Nubeqa to keep it easy.
Nubeqa, Nubeqa.
And Len,
And
are you taking anything else?
no, nothing else. And I feel fine. There's no hot flashes, and you don't feel fatigued, and you don't have brain fog.
So one of the reasons Jim Schrate had Matthew and connect with me is because we were both unusual. He's on long-term catheterization, which is a drag. As I said, I was on it for 8 months. I could not find a radiation oncologist who would talk to me when I had to do treatment, and it pushed me into surgery, and that fixed me. I have not been on a catheter since
Right,
that day.
right.
So I guess the question is, besides the fact that he's on seeing Dr. Schmolowitz, is there a top surgeon in the Chicago system that he could at least
Egner,
have a consultation with to see if
yes,
it would make sense?
yes, and he can refer him to Egner. Go talk to Scott Egner, who's in the who's down there in the same place. He's a great urologist.
You hear that, Matthew? Scott
Yes,
Egner.
yeah, I'm familiar with Eklund.
Okay, so
Matthew,
go ahead, Jeff.
Matthew, before you were diagnosed with cancer, did you have benign prostatic hypertrophy or BPH? You might have been taking Flomax. You might have been taking Proscar. Any of that happen to you?
Yes, with the Flomax.
And did you get any relief with Flomax when you had BPH alone?
With the Flomax alone?
Yeah, before
Because
you had cancer.
I was taking the Lupron and the Flomax.
But before you were diagnosed with the cancer, though, were you ever take anything for the benign prostatic hypertrophy?
No.
And were you symptomatic? Did you have trouble urinating?
No.
So only since you found out you had cancer is when you can't pee well.
Right.
Well, then you should listen to Rick, Len, and everybody else. And otherwise, you're going to have a catheter in there, and big setup for an infection, sepsis. You get with the program and go forward and help yourself.
Yeah.
Okay.
Dr. Jeff, thank you. Thank you for saying that, Dr. Jeff. Matthew, I would say, and I would say you and Kathy need to go sit down with Dr. Schmulowitz again, make an appointment and say, look, any chance of this Nubeca? Because you've heard that it works. And like I say, we've got several guys who are just on only Nubeca. And the second thing is, do you think that I should see Dr. Egner to talk about surgery? Because I don't want to be on a catheter for the rest of my life.
Mm-hmm.
Because, the reason you're on a catheter and the reason you can't pee is most likely, not for sure, but most likely that you've got cancer inside the prostate, and that cancer is squeezing your pee tube that goes through the prostate, and it's not allowing you to pee. So if we take out your prostate, then maybe that will help. Mm-hmm. Sylvester, turn on your microphone, man.
I'm here. Thank you.
You want to talk to this gentleman because you have experience in this area, if I'm not mistaken.
Well, my experience were prior to my being diagnosed with prostate cancer. Many years ago, I had a urethral stricture. I could not urinate. I had to be catheterized every 6 months. When the older I get, I was in my 30s at that time. I'm 85 now this year. When I was in my 30s, I was in the military, and I complained about pain when I urinated. The doctor in the military suggested that I drink more water. When I was discharged from the military, my stricture actually closed completely after about 2 years out of the military. I went to a urologist. In those days, they used something they call sound. and I was hospitalized, and they eventually opened the scripture. After the scripture was opened, I went on an outpatient basis every 6 months and had what they referred to as dilation. Many years later, when I was diagnosed with prostate cancer, I had a prostatectomy, and at that time, I had a catheter. And when I think about 3 or 4 weeks later, the catheter was removed. But that did not go away. That did not stop me from having the stricture. Now, what I understand, scar tissue developed during the years when I had the stricture prior to prostate cancer. Now I have to dilate myself daily to keep the scripture open. But I want to point out something. It's very easy dilating myself daily. It's like drinking a glass of water. It's not painful. And it's very easy for me to dilate myself daily rather than going through the pain and the suffering that I went through with the catheter. Now, when I say pain, it wasn't so much body pain, but every time I had to go to the bathroom to defecate, it wasn't as easy or as simple as it was prior to having a catheter. And sometimes the catheter leaked, and that too created problems. But I'm willing to say, after what, 40 years of being self-catheterized, I'm doing much, much better. And after having a prostatectomy to save my life, I've been in remission for the last 18 years. And I'm happy to be here on this program tonight. And I'm sorry the gentleman is having the agony that he's going through, because there, like you said, Rick, like everybody knows, there are treatments available now that they did not have when I was going through my agony 30 years ago.
Yeah. So,
And I'm sure, being with an expert physician, I'm sure he doesn't have to suffer unduly like he is.
right. So I think the bottom line here, Matthew, is get yourself to Dr. Schmulowitz, talk about the Nubeca, and see if you're a candidate for surgery. Peter, what would you say?
Yeah, I would like. Oh, Peter, go ahead.
It's okay. Well, I said surgery turned me around. It left me with other side effects that continue, but at least I can pee and at least I can hold my urine. But as I said earlier before the meeting when we spoke, you got to have an expert surgeon. You don't want your the guy around the corner in the neighborhood playing around with this. You want to go to the best, and the chances are pretty darn good of coming out of this continent and able to move forward. There's going to be some sacrifice. You might lose some sexual function, but what the hell? I mean, when we're in the 70s, that's not the main thing in life anymore. We're certainly not thinking about having kids anymore. But in terms of enjoying life and going on with our life, that's sometimes the best we can do.
Okay.
Ben?
What's your thinking? How I mean, you've been on a catheter for so long, and as you spoke earlier when we spoke, I mean, the chance of infection and stuff, it's a real hassle. I mean, when I talk to guys who've had surgery and complain about the fact they have to wear a catheter for a week or 10 days, I mean, that's nothing compared to what you're going through and what I went through.
Yeah. Okay, I'll speak to him about the Nubequa.
Yeah,
Speak
it's
to
made
him
by.
about the Becqua and speak to him and ask him whether you can see Dr. Egner to see if you're a good candidate for surgery.
Okay.
Yeah.
Egner. Okay.
And
Okay,
Nubeqa is made by Bayer, like the
Yeah.
ASCO Bayer company.
let,
Okay.
so what I would say right now, Matthew, do we have your email address so we can send you reminders?
Yeah, it's matc7294 at
Hold on a
yahoo.com.
minute. Slow
I'll
down.
send it. I'll send it to you, Rick.
Okay, so Peter has it. We'll send you the reminders. Keep on coming back, and if you're in the hands of Dr. Schmulowitz and Dr. Egner, there's no better team in the country. There may be some that are as good, but there's no better team in the country as Dr. Schmulowitz and Dr. Egner.
All right.
Thank you.
Thank you, Kathy. Stay on his case.
Yes.
All right. Matthew and Kathy, it's a pleasure having you folks on, and we hope to see you again.
And thank you, Sylvester. I mean, you're a legend. I mean, 40 years dealing with this.
Yeah, my goodness.
Yeah, it's amazing. Just amazing.
If
Sylvester,
I
can I
hadn't
ask you,
had good doctors, I wouldn't be dealing with it.
a quick question, Sylvester?
Sure.
Are you intermittently catheterizing or daily catheterization, or you're passing a sound in your urethra to dilate it?
Well, I guess it's similar to a sound. I get a box of catheters each month, a supply of 30 per month. And I catheterize myself early morning when I get up each day. I run this sound, if you use that term. I insert this sound and take it out each day. And it seemed to keep the scar tissue open. But I forgot to tell the gentleman this. About every 9 or 10 years, I have to go to the hospital because sometimes when the sound will not penetrate the scar tissue, I go into the hospital and they use they anesthetic they keep me overnight. They use, I guess, surgical instrument to cut out the scar tissue and put a catheter in for maybe 2 or 3 weeks until it heals and take the catheter out. And I had that procedure done in 2020, 4 years ago, when they had the COVID. And at that time, they did not keep me overnight. They sent me back home. And I've had no problem.
That's great.
And we hope
And
you'll
I
never
now,
we hope you won't have any problems, and we love having you in our meetings, Mr. Mann, as you know.
I've learned so much through these sessions that were not available when I was first diagnosed. But thank God, because I do believe in God, thank God with the information I've gotten on these sessions, all of my T's and all of my I's that needed dotting have been crossed and dotted, and I'm in a better frame of mind because I know whatever I need going forward, it's there for me to get. The
Yeah.
treatments are working, and that's why I attend these sessions.
And Kathy, here's one for you. If you want a little more Sylvester, then you need to come to our Care Partners group, because Sylvester's a stalwart, and we have a Care Partners group to which you're very, very welcome, Kathy. And we don't allow the patients into that. So you can say all you like there, and you can get a little Sylvester man wisdom as well. So
And I like to add something too. I
yeah,
see a lot of men. I see a lot of men on these programs, and I assume they do have wives that care for them. And I think if they encourage their wives to come to some of these care sessions, I think it will help their spouses or whoever their significant others are. I think it becomes a family affair. And I think they would be surprised of the information that their spouses can get to
yeah,
help them cope
yeah.
with their husband's condition.
So we've got to close out now. I can see Len's getting so antsy, but Kathy, in
Yeah.
this room tomorrow night at 7 o'clock Chicago time, we'll be having a Care Partners session, and Sylvester will probably be there, and you are very, very welcome. And you can tell us all about the grief that your old man has been giving you.
Oh my
Okay?
God. That's a
There
whole
you go.
book. Thank you.
Okay, so come on to this exact same place tomorrow night at 7 o'clock. All right. Good night, everybody. Len, thank
All
you.
right.
All right. Good night.
Thanks, man. Excellent.
All right, guys. Good night. Lester, you're my new hero. Thanks so much. Good night, all.